I'll introduce myself. So my name is Emily Hurstak. I am a primary care doc. I spend most of my time taking care of people in recovery at Boston Medical Center, which I love. I'm also the medical director of our OBOT clinic, and I'm kind of in the early stages of my research career, trying to figure out how we can do better, specifically in primary care, which is where I spend most of my time. And I'm going to let my fabulous co-presenter and friend, Alyssa, introduce herself.
Thank you so much, Emily. Hi, my name is Alyssa Peterkin. I also work at Boston Medical Center. I mostly work in the hospital as a hospitalist and our addiction consult service, but I also spend some time in our bridge clinic, Faster Paths. Maybe you've heard of it. We will be talking about it a little bit later on today. And I guess, how could I forget? I am the Addiction Medicine Fellowship Director. Shout out to some alum and current fellows in the audience. So excited to be here and talk about one of my favorite things to talk about, which is alcohol. So I'm going to turn it back over to Emily.
All right. Okay. Have you all scanned? I'm moving on. Oh, no, I'm not. Hold on. I'm going to try. Yes. Okay. Sorry, I went too quick. All right. So this is the title page. I don't think we can see my question, but I noticed on the first day when I was here that somebody asked how many people work in OTPs, and like tons of hands went up. Well, I'm going to ask this again because I want to see who else is here and how we are distributed, because I know there's a lot of expertise and wisdom in this room, and would just like to know who we are and where do we work. Just going to do this for a couple of seconds to see how we are all distributed here. Aha, lots of OTP, a bunch of primary care, a bunch of inpatient, a bunch of acute treatment. Oh my goodness, lots of diversity of practice. I love it. Fantastic. Oh, and it's moving. I don't know why. I'm going to keep going. All right. So you guys are all experts. You know all about this. This is not going to be surprising to any of you, but alcohol use disorder is common. It's been estimated to be about 10% of the worldwide population. It's more where we all work. We know this. And sadly, over 90% of people with an alcohol use disorder receive no treatment, despite coming in contact with all of us all of the time. And it's even lower, the number of percentage of people who get medication. So maybe as low as 2% in some studies are getting medications for alcohol use disorder. So we can do better. Again, this is probably not news to any of you. There are disparities in AUD care as they are seen in other substance use disorders. Latinx and Black patients are less likely to receive counseling, education, referral, medications, and they are more likely to experience alcohol-related health problems as a result. So this is kind of a thought experiment. I would like all of us, people working in this field, to think about, why aren't we doing better with alcohol? There's many probably levels that we could think about to focus on, and there's so many smart people in this room working in so many different settings. So I'm hoping this can be more of a dialogue. So one problem, we don't know if a patient has a problem unless we know the patient has a problem. So maybe we don't identify the problem. So maybe people like me, primary care clinicians, might identify less than half of people with an AUD. And that's despite the fact that the US Preventative Task Force has recommended that we screen adults in primary care settings, I think, for more than 20 years. And, you know, that screening and then a brief intervention for people who are found to have harmful or unhealthy alcohol use actually does improve, you know, alcohol use behaviors. So why don't we do this? Probably lots of reasons. This is a stigmatized medical condition. We have bias on the clinician level. We have maybe a lack of education or tools that we feel like we can do this well. We have lots of time constraints in a 15 to 20-minute visit. I know I feel that. And then I think there's some technological issues that really, like, we could set up systems to actually help us do this better and more efficiently so that it actually happens. And what about all the other settings, which many of you guys practice in? Screening is happening in the emergency room. There's actually been a number of studies done on screening and brief intervention in the emergency room with somewhat variable results, and also in the hospital and also in SUD treatment settings where we all practice. And I think, you know, those are all wonderful opportunities for screening. But I guess if we do the screening and we find the problem, what do we do with it? So maybe even before that, about documentation. So that's the boring part. None of us like, or at least maybe I'll speak for myself, I don't like the documentation part, but it is important. It's some of these studies have shown that actually positive screening has only been documented a third of the time. So we've actually done the screening, but then not put it any place useful to help our patient or help each other take care of the patient. And documentation actually might be even lower in practices that have high social deprivation index scores. So practices that, probably have patients and communities that have lots of social determinants of health needs. We know that electronic health record solutions can help flag alcohol-related problems and screening results, and these are often underutilized. And I think also we underutilize our other, let's say, non-prescriber clinicians on the team to help us engage with screening and documentation and even brief intervention. I think the question is, if it isn't documented, did it actually happen and does it actually help anybody? Maybe not. What about treatment-seeking factors? So I want to step back for a minute, because whenever I hear that phrase, I always think of it sounds very patient blamey. Why isn't the patient seeking out care for the problem that they have? Often I think that term might reflect really a treatment barrier. But we do know that there's a long delay before people who are first diagnosed with an alcohol use disorder seek treatment. It can be anywhere from 8 to 14 years based on some epidemiologic studies. And we know a lot of health complications and impacts on people's quality of life can happen during that long lag time. There is this concept of natural recovery in alcohol. I think it gets brought up in alcohol maybe more so than other SUDs, although I imagine it happens in all substances. But the idea that folks who are engaging in really unhealthy and perhaps harmful alcohol use sometimes age out of it. And I think maybe, that may be true for a percentage of people. We don't know who those people are, and using that as an excuse for that, significant delay in treatment obviously would be unacceptable for the many people who are experiencing harms in the short and long term. So again, why aren't people seeking treatment? Again, we've got stigma. We also have the unique aspect of alcohol being legal and use being normalized. And then I will say, so I work majority with people actually who have an opioid use disorder. And I think the knowledge about the medications for AUD among our patients actually is much lower. So a lot of folks I take care of are very familiar with disulfiram, or also known as antabuse. So a medication that you definitely do not want to consume any form of alcohol on, or you will feel terrible and maybe even wind up in the ICU. I've actually took care of a patient like that in residency. But we have other options, right? Where you can continue to drink, to drink alcohol if that is consistent with your goals for recovery. And I find a lot of my patients actually don't know about those other medication options or those other maybe more harm reduction behavioral models as well. So I think that's on us to make sure that people actually know what treatment for AUD looks like, and that it's not just abstinence only, and it's not just treatment for withdrawal. Clearly, there's a clinician bias problem. A recent grad, I think from one of the fellowship programs in Boston, actually published a study that showed that PCPs who have positive attitudes about alcohol use disorders are more likely to prescribe medications. Probably not super surprising, but obviously just further reinforcement that this matters, and that our attitudes and views on this issue obviously influence our own behavior. So why take care of this problem in primary care? I think a lot of us are familiar with SBIRT, courtesy of our fabulous late colleague, Dr. Richard Sates. For those of you who haven't heard about SBIRT, the S stands for screening, the B and the I stand for brief intervention. That's, some brief counseling that you might give to somebody who's engaging in unhealthy alcohol use. And then the R and the T are referring to specialized treatment for people who actually have an alcohol use disorder that you diagnose with the DSM criteria. So again, it's been recommended now for many years. It is not actually that consistently or routinely implemented in primary care practices. And there are some limitations. It's brief intervention has shown to be beneficial for folks engaging in unhealthy alcohol use, so maybe drinking 4 or more drinks a day. That's been shown in Cochrane reviews, but really no consistent evidence of benefit for people who have a full-blown alcohol use disorder. So what does SBIRT recommend? They recommend specialized referral for alcohol use disorder. So I will pose this question to all of you. What do you consider specialized alcohol use disorder care? You can choose more than one. Doesn't work this time. Oh, no, it does. Yes. Okay, lots of things. All the things. Many things. I agree. I would have selected everything on the page, and it turns out there's no clear definition that I could find in any of the literature on what constitutes a specialized setting. And I think many of us probably work in what we might think of as specialized addiction care settings. But I think when we know we have a disease that is this prevalent and care that, is this inconsistently provided, probably any and all hands on deck makes sense. So I'm thinking myself as a person who spends time in primary care, how can primary care or general care settings become specialized settings without substantial resource investment? And what do those resources look like? What do we do? This is a little bit of a digression. I don't think I have to make the case that primary care should do this to all of you, but just briefly, it's accessible, it's low cost. Hopefully we benefit from long-term trusting relationships with the patients. Primary care clinicians can treat complications of alcohol use disorder, and actually might be particularly useful for maintenance phase of this medical condition. And there actually have been some studies that show, some better treatment outcomes for patients who have a primary care clinician. I think that probably assumes that their primary care clinician is somebody who treats this medical problem, but if you do, then you tend to do better. And, this talk would be remiss if it didn't bring up what patient perspectives are on this. I think previously we'll get resistance around screening and counseling, especially if it's not done by somebody who has a continuous long-term relationship with the patient. But by and large, patients want to be asked about their alcohol use, and they want people to talk to them about the medication options, not only for their alcohol use disorder, but maybe for related medical conditions, mental health conditions, withdrawal symptoms, and assist, of course, with the other things that are impacting their recovery, like our social determinants of health. So that's probably not surprising to all of us, but just further reinforcement of why we should be doing this. And again, that one study just showing that, patients who knew they had a discussion about alcohol and reported that, only 7% of them in that study actually had documentation of any medication discussion with that provider. So what outpatient models improve care for AUD? If you've heard of any of these, tell me what you think. And improve care broadly, all of the above. Okay. I think yes and no. Like, that's probably what I would say too, but like, yes and no. It depends what outcome you're looking at. So maybe I'll start with talking about chronic care management models. And so chronic care disease models have been, studied for multiple long-term medical conditions, diabetes, depression, heart disease, and have shown to have improved, patient outcomes. They usually rely on a team. Usually there's some technological or information systems enhancements, and they really focus on self-management, that the patient is able to state their goals for their medical condition and is given tools to kind of achieve their goals. And so this has been studied multiple times for alcohol use disorder, specifically in primary care. I'm only showing 2 studies here. One of them, CHOICE, was done at the VA, at 3 VA sites. The intervention was 12 months of an alcohol care manager who was a nurse, kind of like an OBOT nurse, as far as I could tell. And that nurse, had longitudinal interaction with the patient, facilitated referrals, facilitated medications, if that's what the patient wanted, and, interacted with the patient for 12 months. And their outcomes showed a trend towards improvement in heavy drinking days. That's what that HDD is, but actually no overall significant difference. They did see an increase in how many people got started on medications, but that was really the only kind of positive outcome. Rich did a study, I think it was like in 2010, published in 2013, called AHEAD, which was a randomized trial of a CCM. That was actually a full team, nurse, social worker, psychiatrist, and primary care, pretty like high intensity, robust intervention, versus just a primary care appointment and a resource list for people coming out of alcohol detox. So, people early in recovery, alcohol dependent, getting this high intensity intervention. The primary outcome in that study was self-reported 30-day abstinence with a number of other secondary outcomes. And they didn't actually find a difference in abstinence or heavy drinking days. They did see a decrease in alcohol-related health problems. I think in health-related quality of life was improved. And they also saw an increase in medications for the CCM arm. The SPARK trial is a little bit different. This one's not really a CCM model, but randomized clinical practices to basically get something called practice facilitation, where they got training of staff, they got some IT interventions to help them screen and provide counseling and referral, you know, basically education of providers on how to treat AUD. And their primary outcomes were brief intervention for the people who screened positive but didn't have an AUD, and AUD treatment engagement for the other people. And they found that they got more brief intervention, but no difference in treatment engagement for the folks with AUD. And just to kind of round this out, there's been 2 reviews that I could find looking at all of these different sort of integrated care models, you know, CCM models, however you want to label them, basically helping primary care practices treat alcohol use disorder. And the systematic review, which was involved 11 studies, again, they saw increases in medications in, you know, most of the studies that were high intensity, but less consistent changes in alcohol use outcomes. And then the scoping review was really looking at medications specifically, and showed a trend towards improved alcohol use outcomes, but not really, you know, pretty heterogeneous, I would say. So I think we have remaining questions. What are the active ingredients of these interventions to help primary care clinics do this better? How do we implement this? And actually, like, for how long? Some of these interventions were short, some of them were long, like that 12-month one. I think it's pretty unclear. We don't know. And I think one thing that I think about a lot as I'm embarking on my own research career is, what are the outcomes that we're actually measuring? So I only learned about what a HEDIS measure was a couple years ago. So I'll tell you all, I'm actually gonna have to spell out the acronym for myself. So these come from the National Committee for Quality Assessment. And I think it's Healthcare Effectiveness Data Information System is what HEDIS stands for. So it's basically these quality metrics, and over 90% of health plans participate in this, and there's financial incentives. So if you achieve, you know, what they want you to achieve on these different metrics, your healthcare system can get money. So for substance use, here's what initiation is. You receive a treatment for your substance use disorder within the first 14 days of a new diagnosis. And that's actually like new within the last 6 months. And for engagement, you receive 2 or more additional services for your substance use disorder within 34 days of initiation. Where they came up with those timeframes, I have no idea. I tried to find it. I cannot tell you. I think it was expert recommendation, honestly. And what services count? Kind of like almost a lot of different things. Like, I could just write that I counseled the patient in a primary care note, and if I drop an AUD code, that actually might count towards initiation or engagement, depending on where the patient is in that timeline. Obviously, there's lots of other outcomes, you know, that might get closer to patient-centered goals around harm reduction, like heavy drinking days, and then, you know, health complications, and I think, you know, quality of life and functioning outcomes, obviously, really important. So I'll leave you before my fantastic colleague takes over to talk about the next topic, is that, you know, to kind of continue this understanding we have about how we can do better in primary care. I was lucky enough to take over one of Rich's remaining studies. It's ongoing at BMC. That's called Records for Care Enhancement. And so what we did in RACE is randomized actually primary care clinicians to different interventions, but we're measuring the outcome in the patients. So some of us just got EHR tools alone, like clinician decision supports, a smart tool, a flag that like tries to make sure that we don't miss that our patient has an alcohol-related problem. Some of us got clinical care management with a nurse, an addictions nurse, who's basically an OBOT nurse. And then some of us got population health management, where we get shared metrics about how we're doing, you know, treating patients with problematic alcohol use on our panel. We don't have results yet. We are using the HEDIS engagement measure as our primary outcome. So maybe in 6 months, I'll have something to tell you. So stay tuned. But I hope that that'll continue to inform our discussion. So now I'm going to pass it off to Alyssa, who's going to talk about one aspect that we might be able to do better in outpatient care as well.
Thank you, Emily. I was told I have to lean into the mic, so I'm going to do my best with that. All right, so now we're going to transition to talking about alcohol withdrawal. And I think sort of one of my biggest projects or passions is thinking about managing this in an outpatient setting. And so we actually know that mild cases of alcohol withdrawal can be safely managed in an outpatient setting. And outpatient alcohol withdrawal management is associated with decreased duration of treatment and lower costs compared to inpatient. And, as I said, I work at a bridge clinic, so I'll talk about some of the results that I've found with that. But some of the big things that we think about, right? Our patients might not be accessing all aspects of care. Maybe they're seeing you in primary care and they're having these symptoms. Like, what can we do to start them on treatment, right? But because we know that there are barriers to getting them into these inpatient settings, insurance can be a big issue. There might not be beds available. As I said, I work at Boston Medical Center. We have Project Assert right down the hall. But I can tell you that that's a ED-based program that refers people to detox, CSS, and other things like that. But I can tell you that oftentimes people are coming back day after day trying to get a bed. So, what do we do when people come to us in real time? They're like, I want to change my relationship with alcohol, but if I stop drinking, I have withdrawal, right? So what can we do now to help them and overcome some of these barriers? And then also thinking about patient preference, right? As I said, I work in the hospital. The hospital inpatient settings are often not the warmest places for our patients, right? There's a lot of stigma. There are a lot of negative experiences that they experience, and they were like, I don't want to come back. And also, the outpatient setting is less disruptive. It maintains some of those social connections. People can continue working, all those other supports. They don't have to worry about their cat or their dog, right? How many times have you heard like, I don't want to go inpatient because like, who's going to watch my dog? Who's going to feed my cat, right? So we have to think about other solutions to get people closer to the goals that they want to achieve and safely. And so outpatient alcohol withdrawal management might be a way to do that. Okay, so now I'm just gonna talk about a case quickly. So this is just a primer. So I want you to think about this patient as I go through the rest of my slides. So the first thing this patient said to me is, I want to stop drinking. She's 26 years old. She has anxiety and depression, and she's been drinking about 2 bottles of wine every night for the last year. She describes her drinking as out of control, and all she does is think about alcohol. She blacks out after she drinks, and when she doesn't drink, she experiences withdrawal symptoms, particularly the shakes. She's had increased stressors due to an ill partner, and she recently lost her therapist. So some of the supports that she had are no longer there, which have led to her increased alcohol use. When I saw her, her last drink had been the night before, and she was tremulous and she was having palpitations. Her only prescribed medicine in the past had been alprazolam, but she didn't have an active prescription. Looking at some of her markers when she came in, her CWAS score was 12. Her blood pressure was 144/86, and her heart rate was 83, right? So you're seeing this patient in clinic, they want help, think about what you might want to do. So let's pause for the pause, right? So I'm going to walk you through some of the tools or things that sit in my head when I decide what I should do for a patient in this case. So the PAUSE, the Predictor of Alcohol Withdrawal Severity Scale, is a tool that can be used. It is primarily validated in an inpatient setting for medically ill hospitalized patients, but it can be a tool to consider in the outpatient setting to help determine, is someone at risk for a more severe alcohol withdrawal episode. And so there are 3 parts. You look at sort of the threshold criteria, some of the historical factors. You think about, you do your patient interview, so some of the information coming from your patient at this time, and then their clinical assessment. So those are the 3 parts. And if someone has a score of 4 or more, that is likely suggesting that they're going to have a more severe withdrawal course. As I said, this study was designed for, or this tool was designed for hospitalized patients. So it's not validated in the outpatient setting, nor for youth or pregnant people, right? But maybe it's because we're not using it enough, but we haven't studied it yet. But still think of it as a tool in your toolbox. This slide is really what lives in my head day to day in clinic, right? So it's, what are the risks of severe withdrawal? So on the left, you have some of the historical factors, and on the right, you have kind of what's happening in the moment when the patient presents. So historically, have they ever had alcohol withdrawal delirium or withdrawal seizure? How many times have they had withdrawal in the past, right? We know the more someone has alcohol withdrawal, the likely that their next episode could be more severe. Do they have any comorbid medical or surgical conditions? And how well are those managed, right? Is someone looking like they're in heart failure exacerbation? Are they in AFib RVR? Do they have poorly controlled blood sugar? Or is everything else fine? It's just the alcohol withdrawal is a challenge here. And also thinking about how might these conditions impact their ability to engage in care in an outpatient setting or even take medications on a daily basis. And then age, I think that's sort of relative, right? I have plenty of patients who are over the age of 65 who have less medical problems than my 35-year-old patients. So I just keep that in mind. But again, that might not be a problem. And then how long have they been drinking, how regularly, and the amounts. And then on the right, did they just have a seizure? Are they coming to you from EMS? Are their vital signs through the roof? Are they hypertensive, tachycardic? Do they have a detectable blood alcohol level at presentation? So what does that tell me? So if that means that their body cannot tolerate a smidge decrease in their alcohol or their serum alcohol levels before they start having withdrawal. So that means as that level continues to go down, their withdrawal will get more severe. So that's something to keep in mind. And then are they using or taking other GABAergic agents, especially the ones that we might consider using to treat their alcohol withdrawal, right? That can make things a little tricky, but not a challenge that we can't overcome. But where would be the question. And then some other tools in my toolbox, right? We know this, everyone's familiar with the CWA, heard of it before, right? I feel like in my medical training, I was just drilled on inpatient. This is what you do. Every alcohol withdrawal is really scary. CWA, just, butobarb, all those things. But the CWA is a tool that can be completed by clinical staff. It has a 10-item scale, but we also know that there's some language barriers and it's not a great tool for people who are not English speaking. So that's something to keep in mind. But what it does help us determine is whether someone has mild, moderate, or severe withdrawal. So a score of less than 15 indicates about, a mild withdrawal episode. SAWS, which is a tool that I didn't learn about until, I guess, a couple years ago when I was in fellowship, but is the short alcohol withdrawal scale. It's 10 items. 5 are the psychological symptoms, and the others are the physical symptoms. This one can be completed by the patient. So the patient can take home this tool and they can sort of tick off where they, what symptoms they're experiencing in that time. And it's a score of 12 that indicates whether or not someone's having, is a cutoff for mild withdrawal. So these are tools that you can use. One is validated for patient use and the other one is validated for clinical use. All right, so now, again, this is all the information that lives in my head to help me decide what I want to do with the patient. And hopefully will now live in your head too, when you see patients in the future. So I wanted to transition to a little bit of the work that I've been doing in our bridge clinic in Faster Path. So a couple years ago, I gave a talk about outpatient alcohol withdrawal management, and someone was like, well, what's the data in your clinic? And I was like, oh, I don't know. But then, that put me to work to find out what is actually happening. So between it was April of 2021 to January of 2023, we looked to see how many patients had, been started on our outpatient alcohol withdrawal protocol. And so we had 46 unique patients who we only evaluated the first episode. So there are people during this time that might have come more than once, and about a little more than half of them actually completed our benzodiazepine taper. And I think what is even more important is that actually a lot of them, reported a history of complicated withdrawal. So we said, in this case, it was either they had a history of delirium tremens or they had withdrawal seizures. So that's a lot of people. But out of this, only one person actually had a witness seizure. And this was someone who multiple times, we said, this isn't, we don't know if this is really working for you, but we are low barrier in spirit. So we kind of push through till, this is kind of what happened. But I think most importantly, this is to show that this could really work for a lot of patients, especially our low risk patients. Because the person who had the seizure was not necessarily low risk, but we are low barrier. So we still tried to accommodate the patient's interest in going through this process. A couple other outcomes I think are really important and that were super surprising to me was the population that really benefited from us having this low barrier pathway to managing alcohol withdrawal in the outpatient setting. A third of our patients identified as Black and African American, and a third were Hispanic or Latinx. And my understanding is this patient population in our study actually differs from our general population in Faster Path, which is actually more white. So I wasn't, looking to see that, but this was very interesting. And aside from managing their withdrawal, we were able to start them on medications for alcohol use disorder, screen them for infections like HIV and hepatitis C, and link them to recovery coaching. So, it's not just us managing their withdrawal, but getting them sort of the next tools to help them in their recovery process. And just to tell you a little bit about our program, we are in a bridge clinic. We're open 7 days a week. And we have a Pyxis, so an automated medication dispensing cabinet. So we are able to treat people's withdrawal symptoms in real time by just pulling the medication from the Pyxis. And as far as our staffing, we have a nurse there all day, and we have a physician or APP in the morning or in the afternoon. And at this time, we're only using benzodiazepines. And I guess some other important data to share with you. So mean treatment for our patients going through this process was about 4 days. And in the first 24 hours, they received almost 30 milligrams of diazepam. And so this is just to highlight, we love the Muncie et al. Paper. It's like one of the few papers out there that talks about outpatient alcohol withdrawal. It comes from a family medicine journal. And so this outlines the diazepam, because then we primarily use diazepam because that was what was available to us in our Pyxis. And this outlines kind of the sample dosing regimen. It varied by clinician, but at least they had these guidelines available if they, to help them decide what to do or not. But you can see here that Librium or lorazepam could be options as well. There were a few patients who had history of decompensated cirrhosis, and in those cases, we opted for lorazepam as opposed to diazepam. And then the other thing to consider, which as I said, we were primarily benzodiazepine focused because that's kind of what we have in our Pyxis. But I feel like, gabapentin for alcohol withdrawal is getting a lot more buzz. And it's something that you can consider as an option as opposed to, diazepam, Ativan, or the Librium that some people opt for. But we know that it does work pretty well for people who have very mild alcohol withdrawal symptoms, right? So if that's sort of the patient population that's presenting, you can consider this as an option. And some of the other reasons that this might be helpful, there may be less somnolence or daytime sleepiness, and it might also have some effects on their anxiety and help with sleep dysregulation. So there's other reasons why you might want to consider gabapentin as an option. But I will say that we don't really have that signal on its efficacy on DTs and seizures, which, as someone who is trained in internal medicine, I've been trained to worry about the big and scary things, but they don't happen as often as I guess we've been trained to think that they do. Probably like less than 10% of patients who have alcohol withdrawal will have those DTs or seizures that we spend all our time worrying about. And so this is another example of a protocol. This comes out of the British Columbia guidelines. I like this one because I feel like it gives you a little bit more ways to titrate, right? Because we know that all of our patients don't follow the textbook, but this gives us some options. So this one starts with 300 TID, and there's an option for a PRN dose. And then you can see the nighttime dose is a little bit more than the daytime doses. And the goal is really to manage someone's acute symptoms. And if you have to up titrate the dose, you can do that. And then over the next couple of days, you down titrate it over time by 600 milligrams daily. You don't want to exceed 1,300 milligrams on any given day. So this is an option. All right, so getting back to our patient. So this is someone who has a CWAS score of 12. This is her first time presenting for care. And she's having alcohol withdrawal. What do you want to do? Okay, so some people say yes, treat her in clinic. Some want some more info and we have some folks saying no. All right. Can't say I can convince everyone, but my goal here is just to open your minds to other solutions, especially with the resources that we have, right? And thinking about our patients. We want to be patient-centered, and how can we just get people started on, treatment, getting their alcohol withdrawal managed safely. All right, so as I've shared this with you now, I just want to open up to the audience. So what are some other settings that you envision alcohol withdrawal happening outside of the traditional hospital and ATS setting? And what are some of the barriers that you anticipate in your setting? So you all can come up to the mic.
Well, Ruth OT, BHN. OTPs need to be able to do outpatient alcohol withdrawal management because it is a massive crisis when somebody comes in, blows positive on a breathalyzer, and doesn't get their methadone dose. And the concept that we're going to refer these people somewhere else and magically they're going to find an ATS bed, they're going to want to go to an ATS and get fixed. It's nuts. And so I'm challenging actually every OTP person in the room to this sort of sense we have, we can't do anything else. I understand that some of you work for places and seem to have policies and procedures that say you can't treat and you're not allowed to prescribe anything. But that's not written in any of the rules, and I think y'all need to really push back on that one. You actually are requested by SAMHSA to provide nicotine replacement therapy, to do in more and more, and BSAS came out with this document last week about both testing and treating for infectious diseases at OTPs. This one for me is the most important one, is you've got to manage people's alcohol use at an OTP. So at our OTPs, we do outpatient alcohol withdrawal management, just the way Alyssa described. Some people aren't eligible for all the reasons she described, but most people are.
Ruth, do you do gabapentin and benzos?
I do both.
Oh.
Jails.
Okay. Such a powerful response, Todd.
I'm Jen Timich. I'm a psych nurse practitioner at Lynn Community Health and at the Mass General Hope Clinic. And particularly coming from the psych world, the background I come from is, oh, well, you can't give these patients outpatient benzos. So what has your experience been with sort of are patients able to stick to the taper as prescribed? Are there frequent concerns for diversion or using the prescription other than that's intended?
I guess, yeah, I did leave out some really important details for the sake of time, but, you know, thank you for asking that question. So as we're open 7 days a week, we can see people every day. I know that is not possible everywhere, but we either do in person or if someone cannot come back into the clinic, like we've had folks test positive for COVID. So then we switch over to the telehealth model, but we try to see them as frequently as possible. So on a day-to-day basis. So that means we're only giving them about a day's worth of medicine, which will be like, if we give them a dose of diazepam in the clinic, then maybe they're gonna get like 30 milligrams to take home. So not a lot. And then I think as we get further on into the taper course, maybe they might get a 2 days worth of medicine. So it's very, very small amounts. So I think, right, that's always a potential thing, but right, I mean, you know, who hasn't had a headache and asked for Tylenol, right? Like, I think it's common that these things might happen, but we do control the amount of medicine that we are given to our patients because we're able to do these frequent visits.
Let me just add, I have done this. It's easy to be lazy where I work because I can send people to faster paths, but I actually have done this in the OBOT clinic for patients that we felt were lower risk, that we had a great relationship with, and we felt was actually low probability they would go anywhere else. And we have not seen them every day, actually. So we've sent them home with a few days worth. So I think it's just about patient selection. I think you can send people home with meds, especially if you know they have a working phone. They're going to hopefully pick up when you or the nurse calls to check in and see how they're doing, and that you feel like this is a person who will come back if things are not going well.
Thank you. Yes.
Hi, my name is Hiroko. I work in Brockton. I work in the OTP and also on the ETS CSS levels of care. So my question is, I noticed on one of your slides, you said you were able to start, I think it said 52% of people on AUD, which I think is awesome. It's incredible. My experience is that I do typically talk to these patients, especially, you know, patients while in the clinic who are coming inpatient who are struggling with alcohol use. And I talked to them about the medications, but I have to tell you that it's really, really hard to get buy-in from your patients to start on these medications. And then I think I got them and I start talking about Campbell, for example, right? And then I tell them it's 3 times a day dosing, and then I completely lose them. And so I'm wondering if you could just share maybe, you know, are they people who are coming in looking for treatment, or if they're not looking for treatment, like how do you have these conversations? Because I would really love some help and some guidance in trying to get more people to be interested in going on this medication treatment. Thank you.
So our patients come from a variety of sources. We also looked at our refill sources. So some of them come from primary care. Another big referral source was from Project Assert, which is our ED-based program. And so some patients had initially presented to the ED with withdrawal symptoms. They might have gotten, you know, a dose of medication there, and then they're like, okay, I need to go to detox, just sort of thinking that's the, you know, the usual stages. And then Project Assert brings them. I think it's really the multiple touch points that we have with patients, right? They don't like I think about when I do an addiction consult, right? I know sometimes we like just download so much on folks. It's a lot to process. Like maybe you just came here because you didn't want to have a seizure. And now we're talking about treatment, about doing HIV, like it's a lot. So I think we just kind of do small chunks of information every day, and it's another chance to revisit the discussion with the patient on the following day or the next time that we see them. But I think it's sort of variety. Like some people are sort of like, I'm just like totally done. I need all the help I can get. And other people are sort of on different spectrums of where they want to and how they want to change their relationship with alcohol. So I can't say I have all the answers, but I think that just because we can see them so often and engage them and thinking around, you know, what could be possible, that's what gets people started on medication. Yes.
So, last time I was here, I think Alan Wartenberg was here, Richard Saves was sitting up there. And he said to Alan, you detox personally 40,000 people. And Alan said to me, you've just detoxed over 40,000, supervised. And then he said to Richard, we've done 40,000. So a lot of us have been very engaged in this over time. Anyway, I'm Dr. Arnold Hillman. That's history. This is going back to your comments at the beginning. BI is extremely underutilized in all of North America. It's a simple tool you can use in any ambulatory care setting, but I'm the designer for BI for this, and it has to have the right ingredients, as we said. And what are those ingredients? It has to be culturally relevant to the person sitting in front of you. Be they black, white, red, etc. You know, I've got natives in the rest of it, but it needs to be non-judgmental. Number 3, focus. Number 4, you need to guide. I'm talking more about the artists. You need to guide the patient to insight between their ER visit and their alcohol consumption. Lastly, there has to be some element of follow-up, even if it's just to get consent for a follow-up. Those are the key ingredients to effective PI. And when it's effective, given by people trained, that can be the nurse, the doctor, the social worker, the AUD counselor. It's very, very effective. There's a study which we did with the government of Ontario. It's in Journal of Cogent Public Health, it's the Australian Journal. January 23, 410, Philadelphia, and in cheap, it was 30 to 40% effectiveness. Oh, and it was even.
Gotta get closer to the mic. Sorry.
There was 30 to 40% effectiveness in acute drinkers, binge drinkers who were suicidal. It was even more effective. And the effect of the BI persisted for 3 years. The effect of a single BI well done in a person that was receptive to it. So BI is a good tool that can be easily used in OTP.
I'm sorry, we can't hear anything you're saying.
BI is a good tool that can be effectively used in OTP. And in the study, how do we identify who uses it? Nurse, worker, doctor, identified.
We're gonna have to.
Okay.
Hear the break.
Nurse, doctor, anyone identify somebody who smelled of alcohol or frequent ER visits. Those are the 2 triggers. That's it.
Thank you.
So just, 2 more if possible. If we want to get to anything we want to have. Okay, next and then.
I'm Barbara Tasker. I'm a preventive medicine resident also at Mass Chan. And I just wanted to, I don't have a question, I just wanted to answer some of your prompts. So in terms of alcohol withdrawal in other settings, it's been mentioned before, but correctional medicine, Native American reservations, definitely homeless clinics, I would imagine as well. So those are some settings where we would need to be aware. And in terms of barriers, I just wanted to voice my appreciation that you both mentioned the normalization of alcohol in our culture, which makes it very difficult to recognize alcoholism and also treat it. Because it as recently as the 1960s, 1970s, daily alcohol use was normal. It was part of a ritual, it was just a social ritual, and so I think the culture has definitely shifted away from regular alcohol consumption, but to an extent, it is still accepted. For example, in college-age children, the expectation is that they're going to drink. Even in my previous, like in medical school, previous training, there's a big social pressure to drink. So, thank you for mentioning that.
Thank you. All right, Talia.
Hi, Talia Singer Clark, MD at Boston Medical and BHN. I'm wondering if you have any guidelines for patients who maybe come in for the benzo taper multiple times, like certain number of times in a month, or is there any sort of like number of times that you do this in a certain amount of time before you say maybe this isn't the best setting for you, or any things that you say to patients sort of before you start this, like this is the plan, and if it doesn't work, this is the next step.
That is a great question. I would say sort of in my my review, there were some participants who came back 3 times over the course of our study period. I mean, I think it's sort of, you know, I feel alcohol use sort of is really hard to manage, and there's so many people who will continue to drink, return to use, and so it's not just about like the withdrawal piece, but thinking about like what could we do differently this time? But I think, right, if they're maybe presenting sort of to a more severe withdrawal course, then maybe, you know, if the like we have history to look back on and see how things went the last time. And if things are, you know, if there's concern that it might not be as safe, then I think that's, you know, that's where I would engage them, and they saying like, we've tried this before, it hasn't worked. I think it's now time that maybe we consider the inpatient setting, but at least we have given this an option, a try. I can't say that there's sort of a hard fast rule in faster paths as to how many times. It more so is on clinician judgment, and it's a shared decision making with our nurse and the patient. So we don't have any hard and fast rules yet, but I don't know, maybe one day we'll think a little bit more about this. This is our first attempt at evaluating this process. All right.